let's talk just a second before we start in with the disease processes about some of the kidney. I've already talked on the recording, the pre-recording, about the diagnostics and some of the disorders, if you will. I guess not really disorders, but some of the manifestations that go along with kidney disorder, and some of the assessment pieces. Okay, so we'll get into the kind of the down and dirty of the disease processes. But let's talk for just a second about what we're going to look for and what we need to recognize. Okay, so if our kidneys are injured, if we have an injury to the kidneys, we can have acute or chronic. Okay, we kind of broke that down into acute and chronic, and with the nephrotic and the glomerular problems, you all can just read over that because it's basically where it manifests. So what does the glomerular do in the kidney? So it filters. So if we have something wrong with the glomerular area, then we're not going to have the filtering process, right? So we need to have a filter. We have to have, some of us, our filters are not, sometimes our filters are not very good. So when we think about filter, think about I like to use analogies a lot of times because it just kind of helps me remember things. But think about your window, okay, at your house. Does everybody have a screen at your house? So you've got a filter to keep bugs outside. So if a hole gets in that filter, little gnats can and those little bitty tiny bugs that chase your lights can get through that filter, okay? But you can't, a big bug or a big fly can't get through that filter unless you have a hole in it, or unless there's some kind of defect in there. Maybe your screen's not fitting in there right or something, and so big bugs can get through. So glucose and protein are kind of big bugs if they're not bugs, but if you think about it in that way. So our kidneys keep those things from being excreted in the urine. So when the glomerular is working right, it's going to kind of keep those things from going out into the urine, okay? Because we don't want to excrete those things, in large quantities in our urine. If something is wrong with that filtering process, then those larger molecules are going to be able to get through, okay? And so then if the filtering process is not working, we can see a lot of those manifestations. Now, whether it is acute, so if I say acute, what does that mean?
Short term.
So it's short term, right. And so if it's short term, then the patient's probably going to recover, and they may have some residual effects left from it, but they may not. They may just completely recover and never have another problem. If it's chronic, it's going to be a lifelong thing that they're dealing with. And so if we see chronic problems, then we're going to have to implement some interventions to combat those problems, okay? So I just wanted to talk about that for just a second. So let's see if there was anything else. Your book just kind of breaks down that first little section of chapter 54. It just breaks everything down. It talks about fluid and electrolytes, and some of the common problems. If you all will look at that table on page 1568, some of the common problems with fluid and electrolyte disturbances, and you all have already had fluid and electrolytes. So hopefully this right here is a review. But, if we see these manifestations because the kidney's not working, you all, I probably talked about when you talked about fluid and electrolyte imbalances before, about how the lungs work with the kidneys to rid ourselves of waste. And so that's what our kidneys are doing. And if they're not working, then we're going to have those fluid and electrolyte imbalances because the kidneys work with the lungs. So, and before I forget to say this, I want to say this about ACE inhibitors, because, and we'll talk a little bit about some of the drugs, but we see a lot of folks that are on, have kidney dysfunction, that they put them on ACE inhibitors. Because remember, when you listen to the lecture and you look in that first chapter, chapter 53, that renin-angiotensin system goes into play to help regulate our blood pressure, okay? And if our blood pressure needs to be elevated, then we're going to have that system triggered to raise our blood pressure. Well, ACE inhibitors block that and keep the blood pressure low. Okay, that's what their job is. They're an angiotensin converting enzyme inhibitor, an ACE inhibitor. So what would be some of those medications? Does anybody know?
The endocrine.
So the prils, lisinopril, captopril, or capitan, those medicines, those classifications of drugs, we see a lot of times in renal patients because they help to lower the blood pressure in the kidney, and they have a protecting mechanism in the kidney. So nephrologists love those medications. So what is the side effect of an ACE inhibitor? What's the biggest side effect? Coughing. So why do we see coughing with lisinopril? Anybody know? Because of the properties that happen in the lung. The lung has properties in it that those ACE inhibitors, they work for. So if a patient is going to start coughing and have the side effect, it's going to be quick, okay? Probably within the first week. If somebody is on an ACE inhibitor for long term, they can have long-term residual effects from it, but most of the time it's going to happen quick. So if somebody starts coughing, they can drink water, they can take cough medicine, they can use cough drops. It is not going to help, okay? It's because of how that the drug is working on the lung, okay? So just remember that. You don't have to, like all of the intricate little things. So let's talk about and break this down into acute, and how are we going to manage acute, and how are we going to manage chronic, okay? And I'm glad you all put those up here side by side so that you can kind of see. So with acute kidney injury, that can come from several different things, and they have those listed up here. So we have hypovolemia and hypotension. So if we have hypovolemia, we're probably going to have hypotension, right? So what could cause that? What's some of the things that can cause that?
They're urinating too much.
Okay, so they may be urinating too much.
Not taking in enough fluid.
They're not taking in enough fluids. So what else can cause it? So we think about hypovolemia. What do you think about when
they're sick?
Okay, they're very, very sick. So somebody has, even if they're dehydrated, they get like a GI bug and they get dehydrated. We can classify somebody. How many of you all have taken care of somebody in the hospital with an acute kidney injury? Okay, so that may just be that their lab values are elevated because they have had a GI bug or something like that. Okay, so other things that can cause hypovolemia are like trauma, because they've lost a lot of fluid volume. They may have lost a lot of blood. Surgery, that they may have had surgery and lost a lot of blood in surgery, or they were under anesthesia for a long time. Somebody who has a burn, a burn victim, they can have acute kidney injury because what is our, when somebody has a burn, what happens to our vascular space?
Fluid just comes out.
So everything, we have fluid leaving that vascular space, but we're trying to shunt, We shunt all of that fluid and blood to the vital organs, which the kidneys are a vital organ, but we lose a lot of fluid whenever we have a burn, okay? So that's one of the times that, you know, we gotta be thinking, you know, if some of you all go to work on a burn unit, you know, these folks can have kidney damage. If acute kidney injury is not managed, then it can go into chronic, okay? If we don't get a hold on it, it can go into chronic. Heart failure, so we think about heart failure, and they have too much fluid volume, right? Usually. But notice right here, they wrote decreased cardiac output. So why would decreased cardiac output have an impact on acute kidney injury? What would be the manifestation behind that, or the reasoning behind that? Right. So if they have heart failure, you know, we kind of think about heart failure as, you know, you've got a lot of fluid on your lungs. And yes, you may have a lot of fluid on your lungs, but your heart is not beating well enough to perfuse everything. So the kidneys are not being perfused. So we have to have that, we need to maintain a good blood pressure to be able to maintain our cardiac output and perfuse the kidneys. We need to perfuse. Remember yesterday, some of you all, as you rotated through my room, I said, you got to push hard and fast because we're trying to perfuse the rest of the body. So when you're if you're not perfusing, you're not getting blood to the brain, to the kidneys, to the heart, to the lungs, okay, and the liver and pancreas. We can also see it from obstruction. So somebody comes in and they have a urinary tract infection. They've got a stone in the ureter. They have kidney stones. You know, we can see decreased urine output because there's a blockage there. So nothing is getting out. So, you know, it causes some kidney injury. So we can see it there. So what is the patient, how's the patient going to manifest? What are we going to see out of the patient? So they may be critically ill. So if somebody has hypovolemia, they could be very ill and they could have hypotension to go along with it. If they're just presenting, you know, and they've got maybe a stone, they may have some severe pain. That may be another. We may see lethargy, because when you have acute kidney injury or chronic kidney injury, our kidneys are not removing all of the waste. So they've got to remove the waste from our bodies. Remember what I said about in liver failure, what happens with ammonia?
It goes up.
So it builds up. And so what is ammonia the end product of? What's right before it converts to ammonia?
Protein.
So urea, protein, and urea. So that breakdown there. So when you think about that, you know, your kidneys are breaking down that urea, which is protein, and so we can have some neurological deficits. It may not be from the kidney, from the liver, but from the kidneys, because you've got breakdown of all of these metabolites in there that our body is trying to get rid of and it can't. So if this lasts for a long period of time, the patient will eventually die because, you know, they're getting buildup and it's going to throw them into metabolic acidosis. Okay, and then eventually, you know, they're just going to keep declining. So we can see with acute kidney injury, dry mucous membranes. And why is that?
They're dehydrated.
Because they can be dehydrated, right? You know, they're not putting the fluids out, but you know, they may also not be drinking, and you know, so they may have they've got hypovolemia, so the dry mucous membranes, and they're not, you know, they're not taking in what they should. All right. We can see drowsiness, headache, and muscle twitching. So why would we see muscle twitching? Calcium, and we can see technique from that. So also potassium. So one of the things that you have to really be worried about, and your labs and assessments are down here. So we've got to do a complete physical assessment on the patient. So you need to check this patient from head to toe. They need to have a neurological check because they may have, let's see if it's over there. So they may be drowsy, but and lethargic, so their level of consciousness may be low. So they may be hard to arouse. They may not be able to talk to you very well. And so if we're looking here at muscle twitching, and that's a calcium and a potassium disorder, so then you can have EKG changes. You could see EKG changes along with that, and the seizures, okay? Because of those electrolyte imbalances. Might not be a neurological disorder causing the seizure, it may be an electrolyte imbalance causing the seizure, okay? So what labs do we want to look at?
Your kidney.
Okay, a CBC and a CMP, so we will put that up there. Okay, so what did you say? What did somebody say?
I was saying your kidney function.
Okay, so your kidney function, so that would be your CMP. So most specifically, what do we want to look at?
Your running creatinine.
Okay, so your BUN and creatinine.
That's down further.
Is it? Oh, okay. I'm sorry. Thank you. I didn't look that far. And then a specific gravity and a GFR. And on the pre-recording when I was talking about the diagnostics, so these right here are extremely important when we're evaluating acute and chronic kidney dysfunction. Okay, your GFR. That GFR is going to tell you what stage of kidney dysfunction that they're in. And there is a table in your book, I put it on the slides, of the stages of kidney disease, kidney dysfunction. And it tells you right there, if the GFR is between these, then there's mild. So how much should your kidneys filter a minute? 125 milliliters a minute. Okay, your kidneys should filter. As your GFR decreases, and with age, our GFR is going to decrease. But I know everything just goes down as we age. I can stand up here all day long and talk about it in every disease process. So as we age, that GFR is going to decrease, and then you compound with something else that's going on, then you can see that the GFR is going to keep going down. So there's more criteria than just the GFR, but we really look at that GFR and that creatinine, and those two things they're gonna correlate. Okay, the higher the creatinine, the lower the GFR. Okay. There's also a test, and it's listed somewhere in those diagnostics in your book, a BUN and creatinine ratio, and that just kind of shows you how much that those two are working together, and it gives you an idea of dysfunction. But you can't look at BUN alone and see the kidney dysfunction. You have to look at the creatinine because that's more of a detailed test based on kidney function. So what is creatinine? What do we test when we're looking at creatinine? What's it the end product of? You may know? Muscle metabolism. Okay. And then specific gravity. So if we're looking to see if the patient is in acute kidney injury, so we've got a BUN that is elevated, a creatinine that is elevated. So what are we going to see our specific gravity do? If our patient is very dehydrated, or they've not got the kidney function that they should, so you're going to see an elevation in your specific gravity too. So what's that? The specific gravity is 1.0 0.25, is that right? Is that right? So this is the high end. Ooh, that 5 is ugly. I don't like that.
Ours is different from that.
Do what?
Ours is different.
1.003 and 1.030.
Oh, well, okay.
That's what on our like.
On your lab values?
Yeah.
Okay, so, but let me just tell you, that is, can be different based on hospital setting, okay? So, you have to know what your normals are, because when they calibrate those machines can calibrate differently in one hospital versus another, okay? So your book says 1.010, I think, to 1.025. Is that what your book says?
The book says that, but our labs,
But your
the
lab,
fake our sheets gave us are different.
Your sheets,
Mhm.
okay. So you're gonna see a specific gravity closer to this end, okay? Closer to this end whenever you've got acute kidney function. So when, you know what, that just reminds me, I don't know if mine is off either,
So I
so
just
I
did.
hate
A
to.
while ago, and I'm glad it's on my phone.
So we can see a lot of manifestations. So signs and symptoms of dehydration. So what are we gonna look at?
Their mouth,
Their mouth,
turgor.
check their turgor, check their skin,
Mhm.
what their skin looks like. You know, and then what's another thing that we can look at here? It's over here. What their what? Okay, so what their urine looks like. So what are we going to look at on the urine? Color, clarity. Feel like y'all are giving meds. Color, clarity, expiration. No. Color, clarity, and like any kind of sediment that may be in it. You know, like the consistency. You know, if there's sediment in there or anything like that, and you might see that on somebody who's trying to pass kidney stones. Okay, somebody that's got an obstruction that's, causing their acute kidney injury, you might see some sediment, especially if they're passing the stones or if they've gone for a lithotripsy and those stones have been broken up. So then they're probably going to be passing some. Somebody has a urinary tract infection and it's really severe, then you may see some sediment in there, okay? If somebody has a Foley catheter, then you might see sediment in that as well, okay? All right, so let's talk about management. So we've got to educate. What do we want to educate? What do we want to tell these folks that's got acute kidney injury? Okay, so diet. So what specifically about diet? What do they need to do? So low potassium.
That's down towards the bottom too. It says high carb.
I guess I need to be reading this, don't I? So high carb, avoid potassium. That's really an important teaching point because, you know, if these folks are not putting out any of, if their body is not ridding itself of waste, which potassium is waste, then we can see those manifestations through chest pain, through muscle problems, you know, muscle cramping and those kinds of things. We see that more with it low, but we can still see that. So we want to educate them on what they need to avoid. So what foods do they need to avoid? Specific foods.
Oh, bananas. You don't have
Okay, so bananas.
Salt substitutes if they're
Okay. Salt substitutes.
because they're high.
What else? Greens. So greens. So what about potatoes? Baked potatoes, any kind of potatoes. A baked potato has as much potassium in it as a banana. That was on, I don't remember any other questions on my NCLEX, but I remember that question was on my NCLEX. A baked potato has more potassium than a banana. And I learned that in nursing school, so I answered it correctly on the NCLEX. I hope. So baked potatoes. What about citrus? So citrus drinks, so orange juice, citrusy type drinks, you want to avoid those as well, okay? Because they all have potassium. You wouldn't believe if you start looking at labels the potassium content. Other things that they want to avoid are things that are like colored, like coffee, cola. So why would that be? So the caffeine would be one thing, but there is phosphorus in that. And so phosphorus can damage the kidneys as well, okay? It's not excreted. So, and what does calcium and phosphorus do?
They're the opposites of each other.
They're the opposite.
Mhm.
So if you've got an elevation in one, you've got a decrease in the other. Okay, so they're
Teeter-totter.
they teeter-totter. So if you're drinking a lot of colas and coffee and those things that contain phosphorus, then that can raise the phosphorus. So if the phosphorus raises, then we're going to have a lower calcium level. Okay, so we want them to avoid this. The kidneys don't rid this phosphorus really well, and when it doesn't, then we can see damage in the kidneys. Okay, it can cause further damage. This right here is probably one of the most important assessments that we can do for our patient. Okay, so we've already talked a little bit about in other disease processes how important it is to get daily weights on patients. But a patient who has renal failure, what would be concerning if you have more than a 2 pound a day weight gain? So they're retaining fluid, and we need to somehow or another get that fluid off. If the kidneys are not working, we got to get another idea. We either got to get the kidneys jump started, or they're going to have dialysis. Okay. After I lectured the other day, the next morning I got up, I gained 2 pounds. I was like, okay, so I've gained 2 pounds, got to take a Lasix. So I had to take a Lasix, and it's idiopathic. We don't even know why I have swelling in my legs and feet, other than just, I guess, being on them all the time. Because my labs are perfect. Everything is perfect. I'm like, okay, I guess I'm good. But, so we talked the other day in class in hepatobiliary or GI1 about how that you weigh a patient and when you weigh a patient and all of those things. So weights and I's and O's. Do we want our I and O to match? Sometimes we really overlook those I and O's, all right? So if we're looking at somebody in acute kidney injury, their intake is probably going to be a lot greater than their output. So, when you're caring for your patients, you want to really, really pay attention to those I's and O's, because that and weight can be one of your first indicators that something is wrong with the patient, okay? Before you ever even look at their labs or anything else, if you're looking back on trends, then you may see that, something is wrong. Renal replacement therapy, I've already talked about. Renal replacement therapy is dialysis. So if you can't jumpstart them, so do we want to just go in there and give these patients like a fluid bolus?
I don't think so.
No, because then we can throw them into heart failure, okay? So we want to really be careful about the fluids that we're giving these patients. Making sure that our IV pumps are set the way that they should, making sure that, that if they're on fluid restrictions, that we are encouraging that fluid restriction. We put signs in the room that when they're making their choices, if they're on a renal diet, then they need to make good choices. One thing we didn't mention about nutritional therapy, what's something else that they need to avoid?
Salt.
So sodium. So they need to, we said don't give them salt substitutes, and then we don't need to give them sodium. So what can we do to make their food taste good? So avoid sodium. And sodium is found in everything. So we may have to put them on, a sodium restricted diet, and they may not be able to have any sodium. So they want a salt substitute. Well, that's got potassium in it. So that's just going to cause them some more issues. So we've got to make sure that we're not, the patient understands the rationale behind it.
It says a lot of people aren't compliant with that, with the salt. If they tell, because it's like their taste buds, it tastes like 2 to 3 months to get used to
And
it.
once you get used to it, I don't hardly salt anything. And the other night, I cooked breakfast for supper the other night, and I was just gonna put a little bit of salt on my egg, and I really salted it, and then I had sausage and biscuits too, and I was like, I told my husband, I put cheese in the egg. I was really needing some protein, I guess, and I was like, this is so salty. Because my husband has high blood pressure and kidney failure, so I have to be careful about the sodium that we use. So we don't hardly ever salt anything. I don't salt much of anything. And we use Mrs. Dash a lot because that doesn't have, doesn't have sodium in it. And I don't know if it's got potassium or not, but I'm like, we got to have something to, to spice our food up a little bit. He says we just need to open it up, throw the food away, and eat the cardboard. That'd be much better for us. Provide psychosocial support. Sometimes we forget about that. And that's really important because these patients are, at that present moment, suffering a life-altering disorder that could lead to long-term effects if it's not taken care of. So, we need to educate them well. We need to provide explanations to them about everything. If they're going down for any kind of diagnostic study or anything like that, we really need to provide an explanation because they're already anxious. You think about your kidneys not working and the possibility of having to do dialysis for the rest of your life. If this doesn't fix itself or the doctors can't fix it, then it's life altering. Let's see. Eliminating the underlying cause. So if it's a stone, they may need to go for lithotripsy. If it's cardiac output, then they may have to go, they may need to be on some new medications, or because we need to get that heart pumping. We don't want it pumping too hard because then that damages those small vessels in there. But we've got to have a blood pressure that's going to perfuse, okay? Because if we don't have the blood pressure to perfuse, the kidneys work on that pressure. It's a pressurized organ. If we don't have the pressure, a normal pressure, then we're not going to have the perfusion. And then watch those. So it's real important to make sure that you're watching your labs, okay, every day. Or if the patient is getting into trouble and you notice that they're retaining more fluid, you need to look at those electrolytes and see, what's their potassium level, what's their sodium level, because are they retaining too much sodium? We've got that small little window on that sodium. So are they retaining too much? And if they are, then they're probably going to manifest that in some edema, okay? And if they've got heart failure, that's going to cause edema as well. So you've got to assess them to see, what's happening here and what's kind of holding hands here and what's going on. Let's look at medications. So K-exolate. When do we give K-exolate? When their potassium's elevated. What about sorbitol? So when their potassium is elevated. So we want to give these two if their potassium is elevated. Sorbitol is going to cause watery diarrhea, and that can help to get rid of some of the potassium. That K-exolate is going to exchange potassium for sodium in the intestine. Okay, so this can be given PO, or it can be given NG2, or it can be given by enema. Okay, if it's given by enema, the patient needs to try to hold on to it for about 30 minutes to an hour. Because if you just give it and they go, I know that's very disturbing to think about having to hold on to it for 30 minutes to an hour. But if the patient doesn't, then it's not going to do them any good, because we want that to exchange for, and pull that potassium out, because this is a potassium lowering agent. K-exolate, potassium, that K, okay? IV dextrose. What does insulin do? What would insulin do? Patient's not a diabetic, or maybe they are a diabetic, but what does insulin do? Right, that's exactly what it does. It moves potassium. If you give the patient insulin, it moves potassium back into the cells, from that vascular space back into the cells. And hopefully they will rid their body of the potassium. And then they may need calcium replacement, okay? If it's something, an obstruction, they may have an infection. It may be pyelonephritis that's causing a severe infection of the kidneys. So they may need antibiotics. They may need digoxin and ACE inhibitors. So we've already talked about those ACE inhibitors. And they could need some magnesium. These patients' lab values may be all over the place. I mean, you may see an elevated potassium, you may see an elevated sodium, you may see a low calcium level. So they may need calcium replacement too. Because what happens when we're talking about the kidneys in relationship to I just lost my train of thought. It just derailed. Because I was thinking about two different things at one time, and I was going to cover both of them. Now I forgot what one of them was. One thing we didn't talk about up here was anemia. Okay, another thing. We see that more with chronic, but you could see it with this if this goes on for a period of time. Okay, so we can see that with chronic. But, so we need to be looking at that CBC, because what does our kidneys make? What does our kidneys produce? It's erythropoietin. So if the kidney is not producing erythropoietin, then we're not going to get the bone marrow is not going to produce, it's not going to produce red cells, okay? Calcium also comes from the bones, right? So if the kidneys are not working the way that they should, then you get all of that endocrine, all of the things going on in the endocrine system to tell the parathyroid hormone to release hormone, and that stimulates the bones to release calcium. So if that's going on, the kidneys are sending a signal that the calcium is low, so it's sending signals. And so the bones are releasing calcium, so we've got a high calcium level, but we've got weak bones, and that can manifest into stones. Okay, stones, bones, I'm just making all kinds of puns up here, aren't I? Okay, any questions about this? Any questions? Does everybody understand and feel okay with that? Feel okay with acute? All right. So let's go to chronic. Switch color of marker here. Move this. So chronic kidney disease it can be caused by prolonged infection. What's some of the other causes?
Got diabetes, mellitus, hypertension.
Okay. So diabetes, hypertension. These are number 1 and number 2 reasons that patients are a lot of times on dialysis. Now there's a lot of other reasons, but not managing diabetes and not managing hypertension causes long-term effects on the kidneys, okay? Some other things, that glomerular nephritis, pyelonephritis. If a patient has recurrent kidney infections, you know, they have chronic kidney infections over time, that can damage the kidneys because they're not getting the perfusion, and it's causing scar tissue in the kidneys from those repeated infections. There can be some things that are hereditary, and then there can be some vascular disorders. What about medications and toxic agents? So what's some of the medications we have to be really careful about? So ibuprofen, NSAIDs. some other nephrotoxic drugs? We call those nephrotoxic drugs.
You said it last night. And then clindamycin. No, that's yours.
So gentamicin,
It is. You're right.
It is. So gentamicin, clindamycin, some of those drugs, some of the strong big gun antibiotics, vancomycin, those can cause nephrotoxic disorders. Okay, they can cause problems. They're nephrotoxic to the kidneys, and they can cause long-term. You know, if a patient's on long-term antibiotic use because they've had lots of infections, or you know they've got some other things. So some types of antibiotics. And your book lists in there several of the medications that are nephrotoxic. Okay, I think there's a pretty good list in the reading. So signs and symptoms. So the patient, when patients usually, if they have chronic kidney disorder, most of the time they've known it for a long time, and hopefully they're managing it and they're keeping the progression at bay. But where we get into problems is trying to manage their disease, okay? Trying to manage the manifestations of the disease. So you all have listed increased creatinine, increased blood pressure, and that those are difficult to manage. So you've got somebody that has high blood pressure and they have trouble managing it. So what are some things? Let's look. We're going to look at signs and symptoms, but what are we going to do over here under the education?
Reducing their salt.
So we're going to decrease their salt. What else? These two things right here can help. So diet and exercise. So when we encourage a patient to maintain the dietary intake, you know, it can be a slow or it can be a balancing act with them, okay? So everything that I said over here about diet is long-term for these folks, okay? So managing and not eating those citrusy foods, watching what their potassium is, watching their potassium intake, being real careful about everything that they eat. So, and then exercising. If they're a diabetic patient, they may not feel like exercising. They can't do things as well or as much like walking. So we might need to encourage them to do low impact aerobics or something like that, like swimming or some kind of exercise like that. Because these people, if they're in chronic kidney failure, maybe stage 1 or stage 2 or stage 3, they're still probably maintaining a pretty decent lifestyle. My husband's been in stage 3 for like 9 years.
Oh, wow.
So he's maintained in stage 3 for about 9 years, but it's because of the things we do, not necessarily that he exercises, because he doesn't exercise a whole lot. He exercises at remote, but he would kill me if he knew. No, he wouldn't. He wouldn't. I tell him all the time he needs to come over here and just stand here and let me talk about him. He's like, I am not going over there. You can forget it. So we definitely want to watch our maintaining our blood pressure, because that's one very good way to keep the pressure down and keep from having longer term problems. Okay. The other thing is managing our diabetes. Okay. So I'm going to put over here under signs and symptoms, increase glucose, because that might not be an exact sign and symptom, but if they're not managing their glucose through dietary, then that's going to complicate our chronic kidney disease. Okay, so is this making sense? How that everything kind of works hand in hand. Now, Oh, you wrote exercise up here. See,
Okay.
I'm missing
okay.
everything, aren't I?
That's okay.
I'm just do what?
I tried to write out beside it too.
I know I did. I did. And then weight loss. How will weight loss help? How can that help with chronic kidney disease?
I don't think your kidney has to work so hard.
Okay, so maybe your kidneys don't have to work so hard. But think about what I said when we were talking about liver disorder. So what happens, think back to cardiac. And what happens when you are overweight, not in everybody, but think about our health status. What happens to our arteries when we eat bad and we're overweight?
You're getting arthrosclerosis.
So you get arthrosclerosis. So does that happen just in the heart?
No, I haven't never.
No. It can happen in every, we get, our carotids get stopped up, our kidneys can get stopped up. So if we maintain a lifestyle of diet and exercise, that can help to combat some of these long-term problems. And patients can maintain for a long period of time. So then let's look at this. Let's look at anemia. So the patient has anemia. What can we do over here in our interventions? Did y'all put it up here?
No.
But you did put treat hyperglycemia. We just didn't put it over here. Okay? So you've got that there. But let's focus on our anemia for a second. What can we do for a patient that's anemic? And why are they anemic? What has caused their anemia and chronic renal failure? They're not producing erythropoietin. It's worse in these folks, okay? We see chronic anemia, so we need to, under our signs and symptoms, we need to put on here, do we have it anywhere? A CBC. We need to look at CBC and look at that hemoglobin and hematocrit, especially that hematocrit, and the red blood cell count. Okay, we need to really be focused in on that when we're doing our assessment. We've got a few things over here under labs and assessment. I guess I should have put the CBC over here under labs. But when we're thinking about these folks, we need to assess that. So if we're seeing that they have chronic anemia, what kind of intervention can we do and can we help with?
Won't they give them? Is there a synthetic erythropoietin?
There is a synthetic erythropoietin. So these patients are probably not going to be in the hospital once they, you may see them. They may be frequent flyers in the hospital, but you have to teach them how to do that erythropoietin. Okay, how to take the erythropoietin. That stuff is expensive too. It is very expensive. So there are synthetic erythropoietin. So it's called, there's probably several different brands. I think your book mentions one.
I think they all end in poietin, don't they?
Yeah, they do. And I don't know, I don't even remember what the name of the one. But your book talked about one.
We have a sheet. I think Edens gave us a sheet.
Okay, Dr. Edens did whenever you all were talking about probably, cancer.
I don't remember what.
Cancer because, the patients with cancer, they have anemia. So you probably will give erythropoietin with somebody with cancer. So with kidney disorder, it is manifesting from the disease process in the kidneys.
Yeah.
Okay, because your kidneys is not telling the bones to produce it, and it's a hormone. Okay, so they can give this subcutaneous, and it's going to take a little while for the body to catch up. A few weeks for the body to catch up. Let's see. So metabolic acidosis. So that may be one of the things that brings the patient in that, we know that they have chronic kidney disease, but if they get into metabolic acidosis, and what causes metabolic acidosis? The kidneys do what? They filter out metabolites. So we see metabolic acidosis because the kidneys can't get rid of everything. So that causes us to have a buildup of acid in our bodies. And metabolic acidosis comes from the kidneys not being able to rid themselves of everything. So you get everything built up in there. So they have lethargy. I think you all put that. It was
on the other people's.
It was on over here,
yeah.
But I'm going to go ahead and circle that and put that over here and draw a little line to metabolic acidosis. Okay? So they are lethargic. My uncle just got into metabolic acidosis back, I think he messed up Thanksgiving. I'm pretty sure he messed up Thanksgiving. So I told him, I said, you just are determined we're not going to have Thanksgiving together. He was in chronic renal failure, and he got sick and started having signs and symptoms. He was lethargic. His blood pressure was elevated. He was very edematous. So we called the ambulance, took him to the hospital. He had metabolic acidosis, and now he's on peritoneal dialysis because his kidneys had completely shut down. So, I mean, he transitioned really quickly, but thankfully he's able to do that at home, okay? So, let's see. I talked about calcium and phosphate abnormalities over there. You will definitely see fluid retention and electrolyte abnormalities. So, where are we going to see fluid retention? What areas can we see that? So their legs, yes. We can see it in their legs. We can see it in their sacral area. You can see edema in the sacral area. It talks about like in the nephrotic syndromes and some of those syndromes, you can see periorbital edema. So you can see puffiness around the eyes and in the face with some of those disorders. But we mainly see dependent edema, maybe pulmonary edema, so they may have shortness of breath. Their lung sounds maybe, they may sound wet in their lungs, so they may have some rales and some bronchi in their lungs. Let's see, what else? You all put heart failure there. So how can we prevent heart failure, and how can we prevent fluid retention?
You're monitoring their fluids, yeah.
Okay, so fluid restrictions. Did y'all write that up there?
I don't think so.
So fluid restrictions.
It's my intervention.
I know, I'm going to start asking now. So fluid restrictions, but let's go back up here. This is how we're going to help to combat that through decreased salt, through dietary teaching, okay? And you've written up here prevention of dehydration in the elderly, and that is really important because the elderly population, you know, they can get into trouble quick and they can lose their kidney function because they don't realize that they're dehydrated. So if they already have kidney dysfunction, then, you know, there's other, that they can go down the tubes quick, I guess, for lack of better words. So let's look at some of the other things. We're going to treat the anemia, and we're going to treat that anemia with the synthetic erythropoietin. So if a patient asks you why that they're going to have to do these injections at home, what are you going to tell them?
Because they will produce red blood cells. And that's
right. And if they're anemic, what signs and symptoms can manifest and what kind of problems can manifest from anemia?
Maybe weak, fatigued.
Weak, fatigued, shortness of breath, because they don't have that oxygen carrying capacity to be able to, you know, get up and go. I mean, basically, you know, that's just one of the things that goes along with it. So you have to really be, you know, careful. Another symptom, as I was reading through the text and everything, I was like, you know, you learn something new every day. My husband has horrible restless leg syndrome. Restless leg syndrome is one of the early signs and symptoms of chronic kidney failure. And I told him, I was like, okay, that's why you have restless leg syndrome and nothing. You know, they have neuropathy. They could have some neuropathy from the kidney failure. And, you know, we think of neuropathy only being from diabetes, but it can be from the kidney failure. And I mean, he sits at night and I'm like, please stop. But he can't, you know, he just can't. And he takes Neurontin and that doesn't help. And he takes Elavil and that doesn't help. And he doesn't sleep well. And he asked if he could take CBD oil, but the transplant doctor said no. They won't let him take CBD oil. So, you know, he's just got to suffer. So he was like, well, I guess I'll just suffer. So one of the other assessments you all put up here, GFR. So remember I said GFR correlates with what? So creatinine. So you really want to watch that creatinine. So this is serum creatinine. And then you've got a 24-hour creatinine clearance. What did you add?
Creatinine will be higher than GFR.
Yes, yes. Your creatinine will creep up and your GFR will go down. Okay, so you'll see that kind of opposite. So what about the 24-hour creatinine clearance? What's that going to tell us?
How much is in their urine?
Okay, so how much creatinine that they are clearing from their urine, okay? How much is being cleared out of the body through the urine? And do they have, so these two right here should correlate, all right? So what about a creatinine clearance? They might do it in the hospital, so it may be something that's done in the hospital, but this might be something that they have to do at home and bring it back to the hospital. So if they have to do this at home, what education are you going to give the patient?
They're going to have a container they have to keep up with. Keep it with them if they travel.
Keep it with them if they're going to travel. And it's usually just 24 hours. So you're going to send them home with it and you're going to say, okay, you need to do this 24-hour creatinine clearance. And this is a test that's really all ordered often with patients who have chronic renal failure. So, so you want to monitor or teach them to make sure that they understand they have to collect all of their urine. But, okay, and I gave this example on the recording. If they start at 8 o'clock in the morning, does that mean I'm going to void at 8 o'clock? And so it's really hard to say, okay, now you start this at 8 o'clock because we don't know what time somebody's going to urinate. So usually whenever they're ready to start it, when they say I'm going to start it, so pretty much first void of the morning. So you get up in the morning, you void, and then once you void, you discard that. And then the next void urine, they collect for 24 hours up until that time, that next morning. So if they get up at 7 o'clock in the morning, they're going to void, and then after that, they're going to collect all of the rest of it, put it in the special container. If they void in the toilet and they get rid of one of them, they have to start all over. So they have to go back, get a new container, because they can't just say, oh shoot, I missed one, because it's a 24-hour. So they have to be taught how to do that test, okay? That's one that's going to be done in the hospital or at home a lot of times. So you want to make sure that they have clear teaching on that. And then the history and physical, I mean, that's a whole lot of what I've already talked about over here, so I'm not going to really get into the history and physical. Treating the underlying cause, so hopefully they're managing so that they're not going to those next stages of kidney failure. But if they're not, then they need to be taught how to manage. And some patients just are not going to listen to you. They're just not, and they're just going to progressively get worse and worse. And, you don't understand how life-altering that dialysis is if you have to go 3 days a week. So, you have to be there. Which now it's where that a lot of these dialysis centers, if somebody wants to go on vacation, they can call ahead of time and pre-arrange so that the patient can go to a dialysis center wherever they're on vacation. So that doesn't limit as much as what it used to. But, you still have, you know, you're on vacation and you're having to go get dialysis while you're on vacation, but I guess it's better than not being able to go on vacation at all. But the patient needs to understand that. Preventing complications and these things that we've talked about, smoking cessation, because what's smoking going to do to those vessels? So you're not going to have the perfusion that you need, and that can complicate the high blood pressure. Okay? So, Lord, that looks like a road map there, doesn't it? I'm sorry. Not really, I'm not. Because that is how my brain works. Unfortunately, I don't know if that's a good thing or a bad thing. So.
I was going to ask, since we grouped it like acute and chronic, do we really need to focus on the specifics about like the glomerular and acute?
I would just skim over those because they fall under these umbrellas. Okay, they kind of fall under. If you can take care of this kind of patient and you can recognize, because they're going to be showing a lot of these same signs and symptoms. That's why I kind of just wanted to group them into acute and chronic, and then Dr. Jones is going to talk about what happens with renal replacement therapies. And I include, she gave you all some slides, and then I included some slides in there for hemodialysis too. You all don't have to worry about peritoneal dialysis. Just worry about hemodialysis. So I've included some slides, and then I think she had some things that she was going to load for you all as well. And then at the end of that kind of groups together, like at the end of those slides, it just groups together the whole nursing process for both of these. It just puts both of these together under an umbrella. Because if you notice, a lot of this stuff overlaps.
So I kind of just study general instead of...
Yeah. I mean, because when you're reading through all of those disease processes, like acute nephrotic versus chronic nephrotic, the manifestations are right here, these manifestations, okay? How are you going to take care? That's what I want to know. Can you take care of this patient, okay? Understanding the pathophysiology of any disease process is very important. You have to understand it. But if you look at those, the pathophysiology is, kind of the same. So, all right, does that help? Okay, good. All right, what's our first thing in chapter 55? I'm so happy y'all like for me to teach like this, because this is like right in my wheelhouse. This is how I like to. So, urinary tract infection, that's our first one. So, these processes, how many of you all have ever had urinary tract infection? Mm-hmm. Ooh, almost every single what, all the time? Did you say all the time? So, does anybody need a break real quick? Okay. So y'all want to take a quick little break? Because Dr. Jones is going to be down here in just a little bit. But these will not take very long. Okay? Yeah.
I'm going to pause.
I drink, yes. Yes.
Wake up, chug, go to sleep.
So we'll talk now about UTIs. And we all kind of know, like, what a UTI is. So this can be upper or lower. Okay, so if it's lower, it can be an infection in the bladder, which is called cystitis. If it's in the upper, we can have an infection in the kidneys, which is called pyelonephritis, or it can be in the ureter. This can be caused from stones in there. It can be caused from migration of bacteria. Now, females are more prone to it than males. We usually see if a male has a urinary tract infection, more often than not always, but more often than not, there is a prostate problem going on. So that the prostate enlarging constricts the flow of urine out the urethra, and when that's constricted, then the urine backs up, okay? So we can see cystitis prostatitis, so this can manifest as prostatitis, so that prostate gland can get infected, and then urethritis, and then and it can be acute or chronic. I mean, you can have, somebody can present with one episode of pyelonephritis and never have it again. Some people just have chronic problems with it, okay? If somebody has chronic problems with it, over time, if it's not treated, it can lead to renal failure, okay? Because you're getting scarring in there from repeated infections, and when you get the scarring, then the nephrons in the glomerular area is not going to work like that it should, so you're not going to get the urine clearance the way that it should. Let's see. Oh, abscesses and in and around the renal area can cause it. So if something happens and they've got something going on in the abdomen, they can form an abscess around that renal area, okay? Tumors, benign tumors, or that may be how they find, you know, a tumor is that the patient presents with nephritis, so that can present itself. So what do we see? What signs and symptoms and what assessments do we need to? I'm looking to make sure that I'm not going to miss anything. So the assessment here, I may not have to write anything on this. You all covered everything pretty darn good here. So assessment, patient, if it's in the lower urinary tract, they come in, they are complaining of frequency and burning with urination, and that they just have to, like, they're just running to the bathroom all the time. They're just, you know, peeing every few minutes. So they may have incontinence of urine. Blood may be showing up in the urine, okay? And this might be microscopic hematuria, which we would have to get a urinalysis for, or it could be gross blood. So when I say gross blood, that means it's visible, okay? So we can see gross blood in the urine. Some people are asymptomatic. So what population of people might be asymptomatic? The elderly?
Yeah.
What other population? What? Children. So what about diabetic patients?
Yeah.
Because they, you know, they don't, their neurons are, they're impaired because, you know, you think about they have nephropathy or neuropathy, they have nephropathy, their pain sensation is not as good as someone who doesn't have diabetes, okay? So they may be asymptomatic until the infection gets so bad that they can even be to the point of sepsis, okay? So, so we can see asymptomatic. So symptoms can happen with sexual intercourse. So what intervention can we tell? You see young people come in after, we call it honeymoon cystitis, because right after they get married, they come in to the ER or to the clinic or whatever, and they're like, got a urinary tract infection. Well, they need to empty their bladder before and after sex, and they also need to have really good hygiene, okay? So real good perineal hygiene, because those things can, microorganisms can migrate. Everything's close in proximity down there, so they need to make sure. And then you all have listed contraceptive practices as well, okay? So maybe they, you know, if they're using some form of spermicide or a condom even, they may have, you know, an irritation to that. So that may be something that they need to take into consideration. Elderly. So why are the elderly, they don't have the sensation, but why are they more predisposed? They hold it because they don't want to go. They may not be drinking as much, so they may be dehydrated. And if they are drinking enough, which their thirst sensation is decreased, so that elderly population, and I talk about some of those geriatric considerations in the pre-recording. So some of those geriatric considerations, you think about, their mobility is not as good, so they're not wanting to get up as often. They don't want to go as often. So we need to encourage them, maybe even some bladder training, okay, to think about, okay, you need to drink, and every so often you need to get up and go. They also have sometimes incontinence, the geriatric population, and this can be for anybody, because you ladies who have had babies know that after you've carried even one, I've only carried one baby, but people who have multiparity, everything kind of gets really, really loose. So you can have stress incontinence, you can have urge incontinence. Somebody may have, some neurological damage that they have incontinence. So if you have incontinence, you think about if they're wearing an incontinent pad. And my grandmother, bless her soul, she's gone to be with Jesus now, but she was 88 when she passed away, and so she had to be on Lasix, and she was a little bit incontinent of urine, and we had a terrible time with her because she did not want to take her Lasix because it made her run to the bathroom. But then she didn't want to change her pad because they cost a lot, and it wasn't like they didn't have the money to buy pads, but she would be like, and so she would get urinary tract infections, which my family, the females in my family, are prone to urinary tract infections. But she was with, Mama, you've got to, you can't do this. You've got to change your pad. But yeah, she was. Well, those things just cost an awful lot. Well, we probably gave 10 packs away when she passed away. But she was funny. But they're incontinent of urine. And so they don't want to drink as much, so they get dehydrated. That can cause a urinary tract infection, or they're holding it. Even people who are working, nurses, are prone to it because, we hold our urine for a long time because we're busy and, you don't have time to go. I know when I was working in the OR, I felt like I never peed, and now I just run all the time. Assessment, UA. So I talked about UAs on the recording. So there's a difference between a urinalysis just avoided, a clean catch, and a urinalysis done by a catheter insertion. So an in and out, or placing a Foley and getting that first urine out of that Foley when it's placed. So you can test for blood, protein, glucose, the specific gravity. So if the specific gravity is elevated, we've already established. If it's low, what does that mean most of the time?
That you're hydrated. That
you're well hydrated. So you can't look at specific gravity alone. You have to look at a lot of other factors and those assessment things, okay? And then a urine culture. So we get the urine culture and then start antibiotics. Okay, you don't want to give them some antibiotics and then get a urine culture on them, because we want to know whatever is growing, what it's sensitive to. Okay, and give them the right thing. Other diagnostic tests. So we can do an ultrasound, see if there's any structural abnormalities, see if there is, anything going on in the bladder or in that urinary tract. We can also do an IV pylogram. I can't write very well sideways. I can't write very well, period, but especially sideways. So an IV pylogram, so they're getting an IVP, so they're going to take the patient in, and what considerations for this test do we need to do? Allergies, because this is a dye test, okay? So they're going to be giving them dye through their IV, all right? Probably going to take them into CAT scan and get an IVP. They can also just do a basic KUB. What's a KUB? Kidneys, ureters, and bladders. So what do you got to tell them about that? Do they need to be NPO? Do they need to do any special tests? Any kind of special considerations? No, your bladder doesn't even have to be full for it. You can just take them at any time and do a KUB. Now, if they're going to do an ultrasound, you know, usually we say an ultrasound NPO, but for a ultrasound of the bladder, they need to be full, okay, so that they can see. All right. Let's see. Meds. So let's talk about interventions before we talk about meds. So interventions, we're going to relieve pain. So how can we relieve pain? You know, it's urinary tract infections most of the time are just more aggravating. They can be painful, especially if it's pyelonephritis. If it's pyelonephritis, they're going to have tenderness over that flank area, that intervertebral costal area, costal vertebral area. So right around here, kind of around this way, they're going to have some pain and tenderness. So depending on where it is, they may have some excruciating pain. And if so, they've listed analgesias here. So we want to give them analgesia. They may have bladder spasms, so they may need some antispasmodic medications if they're having bladder spasms. Because if you're going all the time, feel like you got to go, then that bladder may spasm. All right. Heat to the perineum to relieve the pain and the spasms. This one right here is one of the biggest teaching things that we need to do. Increase fluid intake. What kind of fluids? Water. So water and non-acidic drinks. Okay. So cranberry juice, even grape juice, like cran grape, but we want them to avoid like orange juice, anything that's going to be really acidic. We want to avoid coffee, colas, caffeinated drinks, those kinds of things. Anything that's going to be irritating to the bladder. If I feel a urinary tract infection, I'm probably going to be drinking like a gallon of cranberry grape juice or just grape juice. I'm just going to one right after another, and plus water on top of it. I just might as well be sitting in there in the bathroom until it clears. So what's one of the big, there's a whole list of medicines in your book. So some of the medicines that we can give, one of the big ones is ciprofloxacin. We can give Bactrim. So, you know, some sulfa drugs, those kinds of things with antibiotics. Usually we only do about 3 days of antibiotics for a urinary tract infection. But if the patient is having recurrent urinary tract infections, they may have to be on a longer antibiotic. They may need to be on it for more of a longer course. What's the important teaching about antibiotics?
Take all of it.
Take all of it. Yes, take it all. So you all have done a real good job here listing the things to avoid. And frequently void. Teach that patient, don't hold your urine. You've got to drink plenty to get that bladder and kidneys cleared out, okay? Because if we're sitting there, we'll talk about urinary retention in a second, but if you're sitting there with urine in your bladder, what's it going to do? Breed infection, okay? So when we talk about retention, it can lead to a urinary tract infection if we don't fix the problem, okay? So those urinary retention kind of goes hand in hand. So you all have listed some diagnoses, so acute pain, knowledge deficit, maybe they just don't know what to drink and what to, you know, especially young girls, you know, sometimes you get young girls in there that they're like, oh, really? That's causing that? Yeah. One of the first things that, if you've got a young person in there, what's one of the first assessment questions you need to ask them? Are you sexually active? And then, if they're sexually active, in addition to, let's see, where's the diagnostic test? What's some of the other diagnostic tests that we need to do? Check them for STDs, STIs, okay? STD, STI. Miss Dallins, if she was teaching this, she would tell you that she sees that all the time in her practice because she works at the health department. She's always testing people for STDs and STIs. So you all have listed some of these things out here as far as factors, and we've covered those. We want to avoid complications because then if we get into acute kidney injury, back to those things there, okay? And hopefully we don't get to that place. Most of the time patients will come in if they've got a urinary tract infection. And then sepsis, you know, how many patients have we taken care of at Muhlenberg that come in with sepsis, and it's urosepsis. So it's coming from the urinary tract and it's showing signs and symptoms of sepsis. So hopefully we can change everything with some of these interventions. Avoidance, intake of water, and avoiding these things. Okay, so through our teaching. And if it's long term, we can have chronic kidney disease. Okay. Questions about urinary tract infections? I spent a lot of time on something that we all know about, don't we? But, you know, those nursing interventions, just kind of bringing those to light. Was retention the next thing? Incontinence?
Yep, it's incontinence.
Okay. They are very colorful, aren't they? So, incontinence. So incontinence can be from a number of different things. Can you see that on the?
Kinda, yeah.
If I turn it just a little bit, can you all see it? Okay. So incontinence can happen involuntary or uncontrolled loss of urine. This can be very disturbing to someone, especially females. You know, you think about not being able to hold your urine. This can be from a UTI. It can be from stress, incontinence from lifting, bending, pushing, pulling, straining, sneezing, coughing, anything like that. We've already talked about, you know, multiparity females and how that multiparity can cause stress incontinence and urge incontinence. Urge incontinence is you just feel the urge to go and you can't hold it any longer, okay? So some of the risk factors you all have already listed up here. It can be age-related, that geriatric population. It can also be somebody, you've listed a toilet unavailable, and that's the truth. You know, you're traveling down the road and you just got to go. People who drink a lot, they can have, you know, a little bit of urge incontinence because they, you know, I always, when I'm traveling, I go to the bathroom, like I might go 2 or 3 times. I might be the first one in the bathroom and then the last one in the bathroom, just because like I have mental thoughts about, oh my gosh, what if I get down the road and then I still have to stop 3 or 4 times. So diabetes is a big factor when it comes to incontinence, because what did we already talk about with how that diabetes has an impact on all of the organs, all of the systems of the body. And when somebody has diabetes, it can kind of interfere with those with the sensation of needing to go. So it can lead to urinary tract infections. It can also lead to incontinence. Okay? Menopause. Why does menopause cause incontinence? Okay, so what happens is our bodies are not producing the hormones that we need, and so we get atrophy of that vaginal area, atrophy of the bladder wall, and it can cause incontinence. Men who have incontinence, we've got age written up here, age-related. Men who have incontinence, sometimes that can be related to prostate problems. We already talked about how prostate problems have an impact on urinary tract infections. But prostate problems, especially men who have, they have an enlarged prostate, that can cause some stress and urge incontinence. Men who have had their prostate removed, they they a lot of times will not have that muscular ability to hold the urine anymore. Okay, so they may have anything from like dribbling of urine to incontinence of urine. Okay, so the nursing interventions, we've got to well, let's look at assessment real quick. We got to get a history and find out what kind of problems have they had in the past. So the history and medications, the voiding history. So how often do they go? How much do they go? How much do they leak? Anything like that. And then is there any neurological deficits? If they're running a temperature or they have any kind of disease process going on, they may have incontinence from that, or it could compound the incontinence and make it worse. Okay. Diagnostic testing. So you can do a residual, it's called a cystoscopy. So your book talks about it in a box. There's a box in your reading. It talks about urodynamic testing. And I think I listed that on your slides. In urodynamic testing, there's several things that can be done. They can go in with a scope, look at the urethra, look at the bladder, see if there's any lesions in the bladder. They can do biopsies. They're probably going to put them to sleep if they're going to do anything like that. But they can do some bedside tests. And if it's an incontinence issue, where they're going to do the cystoscopy, but what happens is they go in and we empty the bladder out with a catheter, and then we attach a syringe, take the plunger out of a Toomey syringe, and we count how many milliliters of fluid, and we just gravity put the fluid in there, okay? And then we ask them to tell us, when do you feel the urge to go? When do you feel, and then we document how many milliliters. At the end of that, when do you feel like that you cannot hold it anymore, you're going to have to pull off the side of the road and go to the bathroom? And then we document that, and then we drain the bladder. Some of the things that can happen after that are bladder spasms. They can see some blood in their urine. So they just need all of those things to prevent a urinary tract infection, increase fluids, drink, those kinds of things, okay? We can also see if it's caused from some kind of microorganism, and then teach them maneuvers that can help. So like your book also lists those in the text in a box. So Kegel exercises are one of the biggest things that can help, especially people who are, ladies who are multi-parity. Even for men who have had a prostatectomy, that can help, all right? Those Kegel exercises can help. Fluid management, you know, if they're having incontinence, we don't want them to get dehydrated. We want them to keep their bladder flushed out, but we need to do fluid management. They need to have enough fluid that they're not going to, you know, they're not going to dehydrate themselves. So we may have to find a balance there, and helping them to find a balance, working with the physician. So that would be a collaborative intervention, working with the physician. And then toileting schedule. You know, I talked about that a little bit. You know, okay, you need to go to the bathroom every 2 hours. And if those things are not working, they can use, we wrote up here, warm bath, I think. They can sit in a warm bathtub. They can put warm compresses to the lower abdominal area and that pelvic area. They can do stimulation, but you know, that's kind of getting more into an invasive procedure. So hopefully some of these other things are going to work. The big thing is you want to prevent infection. So you want that bladder to empty. And it may be that they have to be on some anticholinergic medications, or they may have to be on antidepressants, because those antidepressants will help with that bladder issue. Okay. You all have listed about everything up here: caffeine, alcohol avoidance, Avoid diuretics after 4 o'clock because you don't want to get up in the night and have to go to the bathroom. That's going to cause you to hold on to your urine a little bit more. Let's see, and avoid constipation. And early on, they need to keep a bladder diary so that they can, you can determine how often that they're going. Because, you know, especially the elderly population, they think they're going all the time, but really, in reality, they're not. You know, they may fall asleep and think they've, you know, been up to the bathroom 14 times, but they really haven't. So, all right, let's see. Dr. Jones is here, so I'm just going to talk about, I'm going to let you all take a picture of the retention, because this is covered. I mean, there's like 2 paragraphs in your book, I think, 2 or 3 paragraphs. And retention, basically, from incontinence to retention, you know, they kind of go hand in hand, because if you've got retention, if the patient has retention, they may have some incontinence because they're just going a little bit and then they're retaining urine in their bladder. Retention, you've got to think about urinary tract infections, okay? And so some of the things I talked about with incontinence can go hand in hand with retention, okay? So y'all just take a picture of that. And the same thing, the urodynamic studies, the bladder scans. And we can do a bladder scan to see how much urine that they're retaining, okay? Because that'll give us a good idea. All right. So when we talk about kidney stones, the thing I want you all to understand about kidney stones is there's all kinds of stones that can be made, all right? They will, if somebody has a kidney stone and they have to be, and it is passed, they're probably going to test that kidney stone to see what kind of stone it was so that they can avoid what is causing the stone. I can tell you, if a patient presents with a kidney stone, you are probably going to know it before they ever tell you, especially if it's a man, because this is like the closest thing to having a baby that a man could possibly come to. So when I worked in the emergency room as a clerk, I could spot them a mile away. I mean, if a man come in and he was all bent over double and he was just sweating and screaming and everything else, I'd be like, "You got a kidney stone?" "Oh, how did you know?" I'm like, "You just know. You just learn to know." So intense, deep pain in the back. So they're usually holding their back. They're like literally down in the floor, rolling around, can't hardly stand up. You know, I've known patients before that are like, I didn't know if I was even going to make it to the ER because they were hurting so bad and down in the floor rolling, and they had to get somebody, like call an ambulance to come and get them because they couldn't get up and walk in. And it is very intense pain. A lot of these stones look like does everybody know what a cuckleburr looks like? So they look like a cuckleburr, and they've got little spike things on them. And so you think about your little bitty tiny ureter and that stone coming through that ureter, okay? So they will have blood in their urine because everything is irritated. So you'll see hematuria. That can be microscopic all the way up to gross blood, where that you actually see blood in the urine. They may have renal colic. So renal colic means when that stone is moving, it's causing them pain. And then, oh, they feel good. And then the pain starts again. So it's like biliary colic, only in the renal system, okay? And they can get abdominal pain, diarrhea, and pyuria, okay? Lab test, CAT scan's going to show it to you, or an IVP, okay? BUN and creatinine, you're probably going to see those increase. The CAT scan will show you the location of the stone. 24-hour urine test. The big thing is, if you know that there's a stone, they need to strain all urine. So you're going to give them, if they're in the hospital, you're going to put a strainer in the in the bathroom, and you're going to have them to pee through that strainer. It looks like a little cone, and it's got like a mesh in the bottom of it. So strain all urine. And we can do their blood chemistries, and that's going to include this. And then they're probably going to do a UA as well, just to see if there's blood, what the specific gravity is, because they can get dehydrated because they're in so much pain. Interventions, definitely I's and O's, because that's going to give you an indication of what their fluid status is. Okay, and we want their fluid status to be good. We do not want these folks to get dehydrated, because when you're dehydrated, that's just going to make that stone hurt that much more. We don't want, let's see, this right here, that's probably going to be their best friend. They need pain medication. If they have a stone and it's moving, they need pain medication. Okay? Antibiotics, because they may have an infection going on, or if the stone gets lodged, then they may have to have antibiotics, because it may cause them to have an infection. If that's the case, then make sure you teach them about the antibiotics. We've already talked about antibiotic therapy this morning. Cultures to see if there's something causing the stone. There's, like I said, there's all kinds of stones. If you want to know the difference in the stones, y'all can read that in your book, because they gave a nice little description. This one, even if they go home, they need to strain their urine, because we need to know when the stone is passed. Okay, if they can't pass the stone, then we're going to have to think about other interventions. So like lithotripsy, and busting that stone up, and then they're still going to pass that stone. All right, they can go in and surgically remove those if lithotripsy doesn't work, but that's really invasive procedure. So with lithotripsy, they have to go in, and that has to be scheduled, and all of those nursing interventions for a surgical procedure. Okay. We've talked about a lot of those nursing interventions. Patient education, protein intake and sodium intake, those two things can cause problems with, the stones. Avoid oxalate containing foods, spinach, strawberries, tea, and peanuts. Those are four of my favorite things in the whole wide world. So I would be in trouble. You don't want to limit the calcium because of the osteoporosis, but you've got to be careful with the calcium if they're calcium stones. All right, so they have to be real careful. This one right here is, they have starred this, whoever did this board, you starred increase the fluid intake, and that's really important. And then your non-acidic juices, non-acidic. Drinking before you go to bed at night. Most people want to avoid drinking before they go to bed because they don't want to be up and use the bathroom. But they need to hydrate themselves before they go to bed. And know when to call the doctor. Most of them are going to know when to call the doctor, or they're going to know when to come in. Like I said, you can spot them a mile away. All right. So with stones, signs and symptoms, encourage fluids. Know what your nursing interventions are for these tests. Know what to look for with your BUN and creatinine, and your hydration status. That hydration and medications are really important teaching. Okay, hydration can be key to them not having as much pain. All right. Questions? If you have questions, you can email me. There's something not clear. Dr. Jones is going to cover hemodialysis for you all, and I will go and get all my stuff loaded.
Stop this.
Do you want this? Yeah. You want this one?